All right, so today we have Chapter 12, Shock, and Chapter 14, Medical Overview. If we do not get to every last bit and piece of the medical overview today in lecture, that's okay, because that's what we're doing this afternoon when you get here. Anyhow, is we're going to go through some case studies and talk about really what medical patients present like. What are some things we can expect from them as far as what are they going to tell us? Because you've heard me say it once, you've heard me say it twice, you've probably heard me say it 20 times. Our patients don't read the textbook. So it's important for us to be able to kind of connect the dots and make sure that what they're telling us and what we're thinking kind of jive with one another, and trying to figure out which body system's affected, which condition is most likely presenting itself to us, and then how to, and then treating it appropriately. So we'll get into all of that, and we will be off and running this morning talking about shock. First and foremost, somebody tell me, what is shock? What did the book tell you guys?
I think it was a lack of blood supply to a certain part of the body.
I'll take it. And when it gets a bit more progressive, it's no longer even just a part of the body. It is inadequate perfusion, so inadequate blood flow, leading to inadequate oxygen delivery, and that inadequate tissue perfusion winds up leading to inadequate removal of waste products. Shock is a state of perfusion. The cell does not get the oxygen and glucose that it needs. And if the cell is not getting the oxygen and glucose that it needs, what do we know that it is not going to do?
They need it for fuel, so
they need it for fuel. So no fuel, the end result is cellular death. What happens is we switch over from that aerobic metabolism we talked about, where 38 moles of energy are produced, to anaerobic metabolism, where only 2 moles of energy are produced. The cell is functioning very inefficiently. It costs almost as much energy as it does to create energy at that point. And we have a buildup of all those waste products because the tissue is not getting the blood supply that it needs. Blood is the vessel. Blood is what's carrying away either oxygen from the lungs and the heart, or carbon dioxide and waste products from the cell as a result of metabolism. And if that starts to happen, those waste products start to build up. The sodium potassium pump, it's a big fancy concept. And really what it is there is a, for lack of a better term, pump in that cell wall. And it keeps the amount of sodium and the amount of potassium in the cell and in the fluid in the blood at a pretty regulated rate. When that sodium potassium pump fails, all of that acidic waste product rushes back into the cell and causes the cell to lyse. Lyse means the cell is going to explode and die and spill all of its contents, which in turn just promotes more acidic waste product in the area, which in turn makes more cells sodium potassium pump fail, which in turn makes more cells lyse and die, and we start taking out whole swaths of tissue. Then we'll start taking out complete organs and organ systems and organisms, and then the metabolic machine that is our body will fail. And this is only going to last for so long. The bonus for us is it has a pretty defined set of signs and symptoms that we can see both early on, or some more nefarious signs and symptoms that we can see later, which gives us the ability to treat aggressively and do the most good for our patient. So we'll talk some physiology here. The cell is the basic unit of life. Every single piece of our body is made up from tiny little microscopic cells. In order to stay alive, the cells need that oxygenated blood supply. They need an adequate supply of sugar so that they can create energy through metabolism and make adenosine triphosphate. ATP is the energy that the cell is creating. With no oxygen, we create next to no energy, and no energy sooner rather than later means no life. Either that cell or that whole organism is eventually going to cease to exist just based on inadequate tissue perfusion or shock. So knowing what we know so far, I want one of you guys to tell me, what are some of the things that could possibly fail to cause all of this to happen? Because when the body's at homeostasis, just clicking along and doing its thing and maintaining itself very well, this stuff all works quite nicely. What are some
Heart
things that could stop working?
Heart.
Yeah, without an adequate pump to move all that blood around and get it out to the periphery of the body and out to all the cells and tissues and organ systems, sooner rather than later, that adequate oxygenated blood supply is not going to be available. What's something else that could fail?
Trauma. So, like a loss of a cut or laceration or loss of a limb or something like that.
Okay, so you're talking volume now, right? If most of that patient's circulating blood supply has spilled itself out onto the ground because they lost an argument with a chainsaw, we're going to have the exact same sort of issues. And it's not because the heart's not doing its job. You'll see when we start talking signs and symptoms that the heart actually starts working overtime when we have some of these problems occurring. But a loss of blood volume means there's not going to be enough blood to adequately oxygenate the tissues that didn't lose that argument with the chainsaw. So any of the tissues that are left behind still attached to the body are going to start running a quart low, and we're going to go circle right back to that same exact perfusion problem, because loss of blood volume can mean that there's not enough blood left in the person to carry out the business of being a human being and carrying on that metabolism. And what's one other thing?
Central nervous system.
All right, go a little deeper with that. What do you mean the central nervous system?
Brain.
So, okay, the brain, are we talking with like neurogenic shock and that kind of thing? Is that what you mean?
Just if the brain isn't working, your lungs aren't going to work, your heart's not going to work.
Okay, I got you. I'm going to expand on that just a little bit. But the last one we're going to talk about is pipe failure. If the brain or the central nervous system isn't adequately controlling the diameter of our vasculature, so it's not keeping those arteries constricted the way that it's supposed to, and we have wide-scale vasodilation throughout the entire body, think things like anaphylaxis. We've talked about that a little bit when we talked epinephrine. We have pipe failure because our patient hasn't lost any blood. Their heart is still pumping the way the heart is supposed to pump, but we have taken a tank that was supposed to be somewhere between 4 and 6 liters in size and now made it 8, 10, 12 liters in size. We didn't lose any blood, so we still have those 6 liters, but we don't have the ability to fill the tank anymore. And if we can't fill the tank, we're going to lose pressure. If we lose pressure, the heart's not going to be able to circulate that oxygenated blood around effectively. The volume problem is sort of make-believe, but we don't have the volume to fill everything up. And that pipe failure, whether it's from the central nervous system or something else causing it, is going to cause our patient to have some hypoperfusion. They're going to start working their way to and through shock. And the sooner we figure out, hey, this patient looks bad, hey, this patient looks like they are either in shock or well on their way towards being in shock because of a pump problem, a pipe problem, blood spilled all over the floor. And the sooner we start to recognize and correct some of those problems, the better off our patient will do. Shock is a progressive thing. The longer your patient goes into shock, the more negative the signs and symptoms become. The more negative the signs and symptoms become, they eventually get to a point where they are completely and totally irreversible. And even if we manage to get this patient to the hospital alive, they still die from multi-organ dysfunction syndrome, which means multiple organs have shut down and they just die a few days or weeks later in the intensive care unit. So what am I showing you a picture of right here?
Lungs.
Yeah, so on the left-hand side, we have those alveoli, those little grape-like clusters that are going to be integral in getting gas down to the business end. Because when I take a breath in, I fill those alveoli up with oxygen, some other stuff, but we'll say oxygen right now for argument's sake. And those pulmonary capillary beds are woven all around these alveoli. And we have deoxygenated blood coming back from the right side of the heart. So it goes through the pulmonary arteries out to the pulmonary arterial beds, and we have a lot of oxygen in the alveoli. We don't have much oxygen in the blood. So that oxygen diffuses across that one cell membrane thickness from the alveoli into that capillary bed. It gets picked up by the red blood cells. It goes back to the left side of the heart, and the left side of the heart pumps it out into systemic circulation down to now oxygenate the cells, which is on the right side. When we get down to that cellular capillary bed, we have cells that are what? Oxygen rich or oxygen poor? The cells surrounding all that vasculature, they have a lot of O2 left in them or only a little bit?
Should have a lot.
The red blood cells will.
The
The cells themselves have already used their oxygen.
Oh, okay, so the CO2.
Yeah, they've created their energy, they've made those byproducts, and they have a wealth of CO2. The red blood cells in the blood have a high level of oxygen, so we diffuse from the red blood cell now into the cell, and oxygen goes in, provides the ability for that cell to now create energy and metabolize and create ATP. That carbon dioxide waste product senses that that blood now is CO2 poor. So that carbon dioxide, that waste product, moves out of that cell, and that blood goes back upstream to wind up in the right side of the heart, to go from the right atria to the right ventricle, through the pulmonary artery, and right back to the left side of this screen and those pulmonary capillary beds, and it just goes round and round and round every second of every day. This is every cell in your entire body. And when these things aren't working appropriately, our patient winds up in shock. It doesn't really, at this point, we'll get to why it matters and what the differences are. But right now, that is the long and short of it. When we have a pipe problem, we have a pump problem, or we have a fluid problem, our patient's going to wind up in shock. Period. End of discussion. So let's talk the perfusion triangle here for just a minute and see if this helps to sort of drive this point home a little bit. The heart's job is to pump blood. Damage to the heart, whether it is from myocardial infarction, whether it is from anything else that can damage the heart's ability to effectively pump blood, will cause that side of our perfusion triangle here to fall right off. And we wind up with shock related to a heart failure because the heart is not keeping up its end of the bargain. Moving on over to blood vessels. Blood vessels are the container that hold our blood inside. If all the blood vessels dilate rapidly, the body does not have the ability to generate blood fast enough to fill that back up and keep our patient adequately perfused. All of these things, a pump problem, a container problem, or a fluid problem, if there's not enough blood or a patient's lost a lot of plasma from, say, a burn or some significant leaking from anaphylaxis, we're going to have a loss of pressure. Remember, your cardiac system and your vasculature all want to maintain an adequate amount of pressure to deliver that oxygenated blood supply. So what is something, just knowing that this whole system and this whole thing is dependent on pressure, what's a pretty decent vital sign that you think might change some?
Blood pressure.
Yeah, a patient's blood pressure. In the initial stages of shock, and we'll talk about that in just a couple minutes, our patient's blood pressure might be pretty normal. It might even be a little elevated. But as shock progresses and our patient gets a little sicker and a little sicker, we'll start to now see that trend that we talked about progressing downward as far as their blood pressure goes. Because for one reason or another, our body is unable to maintain the pressure in the system necessary to perfuse the rest of the organs. It could be a heart problem, it could be a container problem, it could be a content problem. It really just is on us to figure out what's going on and what we can do to fix it. There's not a whole awful lot sometimes that we can do to really fix shock. Our patients who are in shock are going to require some form of definitive care downstream in the emergency room, maybe at a specialty hospital, depending on what it is that's wrong with them. But how can we fix an inadequate volume problem, do you think?
Tourniquet or, yeah, tourniquet.
I like it, tourniquet. So we stop that leak. That's why now when we do our primary assessment, we're looking for that gross hemorrhage all the time as we're approaching and as we get to the patient, because it's only going to take around 90 seconds for that patient to bleed to death. While I'm farting around doing all those other things, 90 seconds has elapsed. And if this patient had an uncontrolled bleed, we didn't fix the inadequate volume problem. And we're going to bump into some pretty profound shock and hypoperfusion just because now that circulating blood volume is on the ground all around us rather than inside the patient where it's supposed to be. So any decrease in systolic blood pressure can result in inadequate tissue perfusion. Now, I know we talked about assessing vital signs yesterday and we worked on some of that. And I told you it's round about a blood pressure of at least 90, probably 90 plus to have a radial pulse. And then a blood pressure of around 70 to maintain a femoral pulse. And then a blood pressure of around 60. Now, this is all depending on which textbook you read, but we're close. A blood pressure of around 60 to maintain a carotid pulse. The closer in we get central to the body and our lower our blood pressure becomes, the less those other areas are being perfused. If I have to have a systolic blood pressure of at least 90 to get blood down to my radial artery to perfuse the tissues of my hands, and I have some sort of cut or either internal or external hemorrhage that's causing me to lose blood and causing my blood pressure now to be 50 systolic, am I really perfusing the tissues of my hand and probably the lower parts of my arm? Remember, it
No.
has to be a pressure of 90 to feel a pulse down there. So if my pressure is only 50 systolic, I'm behind. If my pressure is only 50 systolic, I'm probably not adequately pumping blood through my femoral arteries either. So really, all I'm doing is keeping my internals, the big uns, my heart, my brain, my lungs perfused at that point, because the body's going to defend those above all else. Decrease in blood volume can result from internal hemorrhage, external hemorrhage. Generally, when we talk about loss of blood plasma, that can help us have a volume problem as well. Remember, plasma makes up about 55% of your blood. It's also the fluid portion of your blood because everything else is pretty much formed elements. So if we have something happen to us, say a burn, a significant burn, that damages all of our tissues and damages those capillary beds and causes those microvasculature and some of the even a little bit larger arterioles and venules to start leaking blood plasma into the atmosphere, we're going to have a significant loss of volume. And that significant loss of volume can really lead our patient towards being in shock. Other things that we worry about as far as not losing whole blood, but winding up in hypovolemic shock, or hypo meaning low, volemic meaning volume, so low volume shock. are things like diarrhea, excessive vomiting, excessive urination. These are things that can cause loss of plasma themselves, but no actual real bleeding. So a patient who's in shock from inadequate blood volume needs an increase of blood volume to restore adequate perfusion. So what's probably going to be our best treatment for this patient?
ALS, so they can start an IV.
So that's going to be our patient who's had those dehydration type issues, or our burn patient. Burn patients require just an unholy amount of fluid to keep them stable. But our patient who's actually got a leak and they're spilling blood onto the ground, the only thing that is going to help them is replacement of that blood that they have lost. So how are we going to provide the best treatment for them?
Try to stop the flow of blood and get them to the hospital.
Bingo. So we want to stop the flow of blood. You go no further until you get that bleeding to stop. And then transport. Transport is going to be the biggest treatment we can offer a patient who is in shock due to inadequate volume. Okay, fine, we can start IVs and do all that sorts of stuff for someone who's had uncontrolled fluid loss, but not whole blood. But at the end of the day, normal saline or lactated ringers or any of the other stuff that they might put through an IV isn't going to transport oxygen and remove carbon dioxide. So we need to plug the hole. At all costs, we need to make sure that that patient does not leak any more blood as soon as we figure it out. Whether that means putting a tourniquet on them, or that means, hopefully just being able to hold some direct pressure. Either way, whatever it takes, the bleeding has to stop. Next, we're going to talk about vessel size. And I think this picture is perfect. If we look at that normal sized vessel on the left, it's filled. So what's going to happen when a pressure wave passes through that vessel on the left? Like the left ventricle squeezes.
It's going to force it through.
Yeah, it's going to push everything through. Now let's look at that dilated blood vessel on the right there. What's going to happen when a pressure wave touches off and hits that?
Not much.
Nothing. It's like waves on the beach. The beach doesn't change. The ocean doesn't change. We'll see a little bit of a wave go through, but there's not enough pressure in there to actually move any of that blood anywhere. To have adequate blood pressure, the vessel tone must be maintained. Now, the central nervous system and some of the other hormone systems are very, very important to all of this. We're talking size of the vessel and resistance created inside of it. That is our systemic vascular resistance. That is how much force the heart needs to beat with in order to get that blood moved. The sympathetic nervous system is what's going to be in charge of all of that. It regulates vessel size. If vasculature gets too big, it's going to secrete off some epinephrine, some adrenaline, and start to shrink down the size of that vasculature. It's going to speed up the patient's heart a little bit because, oh, wait a minute, oxygenation and delivery of oxygenated blood was becoming a problem. So we need my heart to beat faster. I need to shrink down the size of this container so we can restore the pressure. I need to breathe a little faster so that we can get more oxygen in and we can correct this problem. So what are some other things we might see for our shock patient then? We talked to decreased blood pressure, and you're absolutely correct. What are some other stuff we might notice right off the bat? Well, let me ask you this. If when I'm doing my ABCs and I get my way down to breathing and I'm looking at rate, rhythm, and quality, is their respiratory rate going to be fast or slow, generally speaking?
Probably faster.
Yeah, especially in the initial stages. And then I put on some oxygen because remember, oxygen delivery is the problem here, so we need to give them some extra. And then I've finished assessing and treating my B of ABC, and I get to circulation, and when I reach down and touch their radial pulse, you think it's going to be fast or slow?
Fast,
You think it's going to be weak or strong?
probably weak.
Yeah, because we have a pressure problem. And then let's talk skin color, temperature, and condition. If my body's releasing all these sympathetic nervous system agents to shrink down my vasculature and get blood moved towards where it's important, and they're closing off some of the circulation to parts of my body that my brain doesn't really care about, like the periphery, the fingers and toes and things like that. What do you think the skin color, temperature, and condition's going to look like?
Diaphoretic.
Diaphoretic. Are they going to be diaphoretic and warm though?
Cool.
Cool.
Yeah. This is our patient who now is going to be pale, cool, and diaphoretic because they don't have any blood out at the periphery. Blood is all being moved by that sympathetic response towards where it's important. My body doesn't care about keeping my skin looking pink. It cares about supplying adequate oxygenation to the cells of my heart and the cells of my brain and the cells of my lungs. So that's when your patient will start to see some changes in skin color, temperature, and condition. And I got a hint for you. It doesn't really matter if it's because of volume, vessel tone, or pump function. They're going to, this is how shock presents. And some of the minute differences we're going to see are going to tell us, is my patient still compensating? Now, compensating means that their body is still in the fight. Their body is still doing the things that it needs to do to preserve itself and continue on being a human. Then we get to decompensation. Decompensation, when we talk about shock, means the body has expended all of its ability to compensate. The body is no longer even really involved in the argument, let alone trying to win. So we start to see now some of the things that turned on turn off. So that elevated heart rate is going to come down some, and it's going to start working its way down to zero. That elevated respiratory rate is going to come down some and start working its way down towards zero. We'll see some changes in mentation because our patient's blood pressure is working its way towards zero. So we're no longer even able to perfuse the brain. And then our patient winds up in cardiac arrest because there's no pressure, there's no rate, there's no rhythm, there's no quality of their breathing or circulation. And it is all just simply a result of the progressive nature of shock just knocking over the dominoes right on its way. Shock, whether it is vessel tone, fluid loss, or pump related, is the body's legitimate march on its way toward death.
Tommy,
So
I have a quick question. Sorry.
No, go.
When you said earlier, you said maybe like 5 minutes ago, you said weak and fast like the radial pulse was weak and fast. That just, it seems like that doesn't make sense to me because fast always I feel like is strong. So when you say weak, what does that feel like?
It's like barely palpable. When you put your fingers on it, you think that it's there, but it's hardly there. It comes from not only the lack of pressure, but also the fact that the body is starting to close down some of those smaller, less important vessels.
Mhm.
So there's not as much blood going there. And you know, when you feel each other's pulses, and since we all have an adequate blood pressure, we feel a nice, steady, strong pulse.
Mhm.
Now, imagine you were trying to feel that pulse through something. So you put something over your patient's pulse and tried to touch that radial pulse, and you could still kind of feel it, but not very well.
But you
That's
know it's going fast though, because you can feel the.
So the rate is going to increase. The rate is going to increase because of that epinephrine release in your body um, trying to maintain homeostasis and build the pressure back up. But just because the rate increases doesn't mean the quality is going to increase. The quality probably goes down when the rate starts to increase.
Right. Okay. It just sounds like it's confusing because weak and fast. I would think it would be strong and fast, and weak and slow. Then be like, you know what I mean? Because they're like, I don't know. It just sounds better, but like it makes sense now that you say that.
And really, it goes also hand in hand with the other the other vital sign we look at being the patient's blood pressure.
Hmm.
If the pressure goes down, the pressure wave that we're feeling when we measure our patient's pulse is going to go down with it. So we are reducing the amount of pressure, so we are reducing what that pulse actually feels like when we put our fingers on it.
Right. Okay.
So important for us to recognize a patient who is either A, already in shock, or B, well on their way. We do that by looking at mechanism of injury, nature of illness, and we sort of start weighing what our patient looks like, what our vital signs are pointing us towards, and our appropriate emergency care for this patient is really quite simple. We want to oxygenate because the problem is oxygen delivery at this point. The problem is the cells are hypoperfused, so they're not getting that oxygen that they need to provide for their need to create energy. So we oxygenate. Our patient who we think is in shock, we're going to lay them flat on the stretcher. We want them laid out. And really the last two things are we want to keep them warm, because if we let them start to get cold, remember they're going to feel cool to the touch. But if we let them start to get cold, what's the body's usual reaction to being cold?
Shivers.
It shivers. And what does shivering do?
Isn't it the body that tends to warm it?
It is the body's attempt to warm itself. That sounds awful energy intensive, doesn't it?
Yeah. Yeah.
So if the body is falling into this state of hypoperfusion and its inability to create energy for itself when it has to, allowing this patient to be cold and start to shiver and expend more energy means now we have an even bigger oxygen demand, we have an even bigger glucose demand, and we already can't supply it in readily enough to begin with. And our shivering is actually helping this patient die faster. So oxygenate, lay them flat, keep them warm, and above all else, transport.
How would we keep them warm? Do we have like a type of blanket in the
Yeah,
or
there's blankets in the truck. The heaters in the truck, you can get that thing cranked up to practically 80 degrees in the back of that truck.
Mhm.
We have those like tin space blanket things too, so we can almost wrap our patient up like a burrito and use what's left of their body heat
Right.
to warm them up. It's just don't let them get cold is really the long and short of it, and keep them as toasty as you can. All right, we're gonna take a short break here. I don't want to go in big chunks when it comes to this, because I want you guys to all sort of get and understand and digest this, and I want you to ask lots of questions if you have them, because this is big business, and one of the best things we can do is figure out shock, its signs and symptoms, its treatments, and the ways that it kind of presents itself and what is actually going on inside of our person. So why don't we take 10 and we will come back and go over the categories of shock. So now let's talk our different categories of shock. So this is a very loud picture, but it works because all of this stuff leads right back to the middle. We're going to talk shock. We'll start at the top, noontime. We have hypovolemic shock. Hypovolemic shock is either going to be hemorrhagic, so the result of a bleed, or non-hemorrhagic. Those non-hemorrhagic causes we talked about were burns, prolonged diarrhea, prolonged vomiting, even like the world's worst sunburn, depending on patient's age and basic health, could cause some fluid shift problems and could cause our patient to be hypovolemic. Think of a tiny little baby, right? Covered in those sunburn blisters. They don't have a lot of blood to go around. They don't have any extra plasma. So if they're covered in those blisters that are actually filled with blood plasma, they're going to have some hypovolemic issues. Next, we'll move on down to our cardiogenic shock. So we already talked from myocardial infarction. So a patient has a heart attack, part of their heart muscle dies, and that heart muscle will never pump again. So it's going to significantly sometimes limit the amount of pumping that the heart is actually going to do. So anything that's going to depress the pump's function is going to cause some cardiogenic shock. Could be an abnormal rhythm. It could be our patient has been prescribed a new medicine, like certain medicines for blood pressure. Beta blockers or calcium channel blockers are both really good blood pressure meds. But if it's new to your patient or your patient accidentally took too many, it's going to limit the heart's ability to adequately pump blood around. It is very regimented. Remember, we're looking for rate, rhythm, and quality. So that rhythm, if anything causes that to be abnormal, either too slow, too fast, all sorts of weird, it's going to start really affecting the heart's ability to be an effective pump. And then this next one we'll talk about briefly is congestive heart failure. Congestive heart failure is just that. The heart is having a difficult time for one reason or another, and we'll talk all the reasons when we do cardiology, pumping out the blood that's there. Either blood isn't getting back to the heart effectively, and the heart obviously isn't going to have anything to pump if blood isn't returning, or the heart gets engorged and can't get all the blood out. So congestive heart failure is got a couple of different causes and a couple of different presentations, and it's really going to limit the heart's ability to pump around blood because either A, blood's not getting there, or B, blood just isn't really adequately being moved. We're going to skip over metabolic and respiratory here for just a minute, and let's talk obstructive. So we have a couple of different things here on that little obstructive chart. So first we'll talk about tension pneumothorax. Tension pneumothorax. You remember the mechanics of breathing, right? My diaphragm contracts and pulls forward. My intercostal muscles contract and expand my chest wall out. And I have created a negative pressure inside of my chest that causes gas to rush in, fill my lungs, go down to my alveoli, and get to the spot where gas exchange takes place. With a tension pneumothorax, for one reason or another, when I go to create that negative pressure inside my chest, gas escapes and leaks into my chest cavity. And with every breath I take, more gas leaks into my chest cavity and will eventually cause one of my lungs to actually go down. We will have a lung that no longer inflates. And then the more I breathe and the more gas that escapes and gets trapped inside my chest, we'll start to see the other lung being affected. We'll start to see some obstruction in blood flow getting back to the heart. So your inferior and superior vena cava run right through the middle of your thoracic cavity back to the heart. Your venous side of your vascular system doesn't have any pressure really built up in it. So when that pressure builds to a certain point in your patient's chest, it will actually collapse the vena cava. And that obstruction will prevent now any blood from getting back to the right side of the heart. And if blood doesn't get to the right side of the heart, where else isn't it going to go?
To the left side.
Yeah, to the left side, to the lungs, or to any of the rest of the body. So we have blood flow being obstructed in a tension pneumothorax just by a buildup of interthoracic pressure. Now we'll move to that pulmonary embolism. In the heart, when we have a myocardial infarction, those coronary arteries get blocked, and oxygenated blood supply is not able to get to that little piece of heart tissue. When we have a pulmonary embolism, we have a blockage in our pulmonary arteries that prevent blood from getting to those pulmonary capillary beds, and oxygen can't get picked up. So we have another obstruction of oxygenated blood supply, causing our patient to now not be able to support the needs of the body and transport oxygenated blood flow around, and our patient winds up right back in the middle of this picture to shock. And then we have pericardial tamponade. When we talked about the mechanics of breathing again, we talked about that visceral and the parietal pleura. And it's a sac that the lungs sit in to make everything happen nice and fluid. Well, the heart sits in a sac too, called the pericardium. And it is also very close to the heart. When the heart expands and contracts, sometimes blood can actually leak into that pericardium if there's a leak anywhere. And every time the heart contracts, more blood gets leaked into the pericardium. And then when the heart goes to expand, if blood is taking up space in the pericardium, the heart can't expand back to its normal size. So it expands a little less, and then it contracts again, and it squirts more blood into that pericardium. And then since more blood is now in that pericardium, the next time the heart expands, it still doesn't expand as much. And then it contracts again, and the cycle just continues until the heart is being so squeezed and under so much pressure, it doesn't really have the ability to expand and contract anymore, and blood flow is obstructed again. So next we'll talk distributive. We have anaphylaxis, neurogenic, and septic. Anaphylactic, we talked pretty good about that when we talked about epinephrine on Friday. What happens in anaphylaxis or anaphylactic shock? Our patient's immune system does what it does every single day. It has identified something as an invader to the body. But instead of handling and managing it appropriately and doing its normal thing, it freaks out. And it sends off all these chemical mediators, all these cytokines, and releases all this histamine. And it expands the size of our patient's vasculature. And we have wide-scale vasodilation, and we have capillary leakage. So now we're losing plasma. We have a whole bunch of other physiological processes that are going on. And it is really just as a result of your patient eating a peanut that they shouldn't have, or being stung by a bee. It is just a systemic reaction to something that is really not as big of a deal as the body is making it. Septic shock is much in the same vein. Your patient will have some form of infection. With elderly people, a lot of the times it winds up being something like pneumonia or a UTI, something that doesn't make us particularly sick. But their body and their immune system has sort of lost the ability to fight some of that stuff off. And sooner rather than later, some of those infectious particles will spread throughout the body. And when that happens, you have all of these bacteria just floating around, and they cause vasodilation and capillary leakage. So if we have vasodilation, we have a tank that's too big. And if we have a tank that's too big that's also leaking, we're going to have some problems, and it leads us right back to the middle of this picture again, and we wind up in shock. And last but not least, let's talk neurogenic here for a second. So which part of the nervous system, do you guys remember from the beginning of the lecture here, is responsible for vascular tone? It was part of that fight or flight response. It's the body's coping mechanism for a lot of this stuff. All right, it's the sympathetic nervous system. The sympathetic nervous system is the one that releases the epinephrine that helps control our vascular tone. Neurogenic shock will happen pretty soon after a spinal cord injury. What happens is our patient will have a spinal cord injury. And when we look at our patient, from wherever the injury happens, so let's say it happens like right in the middle of my thoracic vertebrae, I have a spinal cord injury. You'll look at me from the level of the injury up, and I'll be pink, warm, and dry. Things will be looking like they're going great, other than the fact that I can't wiggle my toes and can't feel my feet and all that good stuff. But then from the middle of my thoracic spine, the level of that injury, my brain's not able to send those chemical messages, those electrical signals to the rest of my body. So from the middle of my thoracic spine on my entire body, the whole way down, no sympathetic response can be generated because no nerve impulses are getting down that far because the spinal cord's not intact. Spinal cord is the highway that delivers all these messages. And I will have wide scale vasodilation below the level of my injury because that sympathetic response, all of that epinephrine that's supposed to help constrict my vasculature and keep vascular tone, can't be sent down there, and nothing is getting through to tell my vasculature, hey, you need to clamp down a little bit and increase the pressure so that we can provide oxygenated blood flow and glucose and removal of all those byproducts. And our patient circles their way right back to shock. How's this going? Was that good for everybody?
Yeah, so there's obviously a bunch, so all of the like the septic shock, but like you put all of the like what, there's 5 there. So but there's a bunch in the textbook, like all differently separated. So but that's like those are the main 5 types of shock. Is that why you put them like that?
Yes, it is.
Okay.
These are the 5 big ones.
Okay.
Now, I breezed by the metabolic and respiratory. This is not quite as common. Metabolic and respiratory shock will happen when the body has a difficult time either carrying oxygen, offloading the oxygen, the cells aren't using it appropriately, something's causing oxygen to not diffuse across the cell walls like they're supposed to. The other 4 are much, much more common. But if we see a patient who is exhibiting signs and symptoms of shock, and we see a problem with, say, I don't know, hyperglycemia or just a weird respiratory rate and pattern and things like that, and we can't put our finger on one of these other things being what's causing our patient's shock, it stands to reason that we're probably getting towards metabolic, which would be the hyperglycemia. High blood sugar will actually make a patient's blood acidic, and oxygen does not come off the red blood cells as easily when a patient's blood is acidic. Or we'll see maybe in some poisonings that the oxygen is having a difficult time diffusing. And really, there's not a whole bunch we can do for any of those except for maintain our ABCs and respond to any of those things that arise. And we can't fix hyperglycemia. We can't fix someone who has been poisoned out in the street. Our treatment's going to be provide good oxygenation, lay them flat, keep them warm, and transport them somewhere where definitive care lives. That's really the take-home message for a lot of these shock considerations. Because if we look at this list, right, we have 5 different kinds of shock. We have all sorts of different arms coming off of those 5 different kinds of shock. And how many do you actually have treatments for? I count 2. We can treat anaphylactic shock. We can treat hemorrhagic shock. And that's really about it. So a lot of this is going to be recognition and response, because we're not fixing these problems. Shock is progressive and needs actual correction.
So basically, get them in the ambulance and hit the gas.
Yeah, they need oxygen and a diesel bolus.
So I have an example that I don't think I went into shock with this example, but I was at work at a restaurant, and I picked up there was like this microwave above us, which is not safe at all. And the cook asked me to grab something out of the microwave, and I didn't know what it was, but I was busy, whatever. I grabbed it, and it's way over my head. And it was really, really hot, and it was just really, it was crazy. It was fast paced, whatever. So I grabbed it. There was no lid. There was no like saran wrap over it. I dropped it down because it was so hot, and all of the sauce came in my face, and like really, really burnt, and like all over my neck and my legs and everything. But the only spot that I was freaking out about was my face. But like
Right.
I got burned everywhere, like my legs, my neck, and like near my eyes. But I was mostly worried about my face because that's what I felt the most. But I don't know if that was like shock or anything like that, because I bubbled over, and like my face was like really messed up for a while. But I ended up going back to work, which I probably shouldn't have. But what would you that's not shock though. Like I was kind of freaking out, like, but
So in the traditional sense, there is still psychogenic shock.
mm,
And that's when you're exposed to something that is like abjectly terrifying.
mhm,
And when that happens, you will have distributive shock. You will have wide scale vasodilation,
mhm,
because holy crap, something just happened to me.
Yep.
And you have that vasodilation, you'll start, you'll feel lightheaded because your blood pressure's tanking, your heart rate's going to speed up, your respiratory rate's going to speed up. And the reason psychogenic shock is a little bit different is because eventually the body just gets itself back on track. There's no like external actual physical piece to it.
mhm,
Now you were burned, so I mean you had the burns and stuff to deal with, but the psychogenic shock portion of it is self-limiting. Sooner or
mhm,
later, your body is going to catch back up. It's going to release that epinephrine. It's going to clamp the vasculature back down. When your parasympathetic nervous system kicks in and decides now to turn off all of the things that it just turned on, you start to ratchet back down, you start to come back into focus, and things start to progress, and you return to normal.
mhm.
You just return to normal with some pretty significant sounding burns.
Yeah. But like once I kind of calmed down and the pain stopped, like, or I mean, it still hurt, it bubbled all over, but that's like a good reaction to a burn. Like rather, it wasn't like fourth, I don't know how many degrees burns there are, but it was pretty significant burn. Um, I can show you guys a picture. It's pretty cool. It's actually pretty cool looking.
Bring those in when we start the trauma lectures here in just a little bit.
I looked like Scarface, but yeah, it was definitely, so that's more distributive, you said?
Yeah, and I think in the book even they talk a little bit more about psychogenic shock.
Yep.
But that's the root of it. It causes that wholesale vasodilation, and then once that happens, you wind up hypotensive, tachycardic. You have a tachypnic, so you have a higher respiratory rate.
Mhm.
And then in just a couple slides, we're going to get to the body's response to all of this.
Mhm.
And the actual body's response to all of this is what makes that psychogenic shock kind of a self-limiting thing, rather than these other kinds of shock where they turn into progressive and bad, nasty, and things just get worse.
Right. Cool. Thank you.
Yep. So I want to show you guys these pictures here of our different kinds of obstructive shock. On the left, we have pulmonary embolism. So if you look at our picture here, we have an artery right there that is blocked. It's got an embolus. It's got a blood clot. And we have with the entire bottom third of our patient's right lung is not getting any blood supply. And if it's not getting any blood supply, the lung is only working at 1/3 capacity, really. So our tidal volume is going to suffer. Our pulse ox will probably go down. Our patient will probably complain of some respiratory distress. And that's just because they can't get enough blood oxygenated to supply what the body needs. In the middle picture was the tension pneumothorax I talked about. We have the lung inside of its pleura there, and the pressure has built up inside of that pleural space and deflated the lung. And the pressure just continues to build until soon enough it starts to put increased pressure right here on that vena cava. And once that vena cava gets enough pressure applied to it, it's going to clamp off and it's going to close down. And once it does that, now we have pretty well shut off blood flow returning to the heart. And if we've shut off blood flow returning to the heart, from there on out, any of the rest of those pumps that our pump is doing is going to pump around absolutely nothing. And then last but not least, we have on the right side our pericardial tamponade. We have the heart in its little sac, and that sac is beginning to fill with blood. And when it gets filled enough, the heart actually won't expand and contract appropriately. And if that starts to happen, the heart now has lost its ability to function as a pump correctly based on the obstruction caused by that blood and that increased pressure inside the pericardium. So I know I didn't warn anybody last time, and I'm going to warn you now. The next picture is a person who's been burned. Burn shock. We take a look at this guy, and he has been burned over pretty much the entire top half of the front of his body. So when that happens, remember the skin's integrity is very important for maintaining our fluid levels. If our skin is damaged and we open up the capillary beds and we open up the internal pieces of ourself to the air around us, our body is a very fluid environment. So the air around us is very dry. If we break the integrity of the skin from a burn, all of that fluid is just going to now come from those permeable capillaries that have been damaged, and it's going to evaporate into thin air. And when that happens, we have a loss of plasma. It's not necessarily going to be a loss of red blood. It's not necessarily going to be because our patient is leaking, all over the floor. It's going to be because that plasma is now no longer contained inside the vasculature like it's supposed to. And that vasculature being leaky is what is causing our patient to progress into shock. Here we have our patient with anaphylaxis. Our anaphylaxis causes that wide-scale vasodilation, same as any of the other distributive shocks we talked about. Blood from the core now is moved out to the periphery because it doesn't have the ability to return. We can't get blood to move anywhere because that wide-scale vasodilation causes a decrease in pressure. That decrease in pressure in the distributive nature of this shock is all the result of the chemical mediators being released by our immune system. And this is one of the ones we have a treatment for. What's our treatment for a patient in anaphylactic shock?
Albuterol.
Epinephrine.
Epinephrine, probably some albuterol down the road, but our first line treatment for this patient is going to be epinephrine. My adult dose, 0.3 milligrams, I am with an auto injector into the lateral aspect of the thigh. I'm going to hold the auto injector for 10 seconds, and then I'm going to massage the area. I'm trying to help that medicine get in quick, fast, and in a hurry because this patient is trying to die quick, fast, and in a hurry. And that epinephrine is going to get inside and cause that vasodilation to now turn into vasoconstriction. So instead of that picture that we saw where the artery now wasn't full, we go back to a full artery, and every time the heart beats, that pressure wave now is moving blood downstream. Our anaphylaxis patients, they're going to show signs and symptoms that they are sick throughout their primary assessment. We're going to see this rash on their chest with the hives, and we're going to hear maybe some airway constriction like that stridor we listened to yesterday. They're going to have hypotension, they're going to have tachycardia, they're going to have a fast respiratory rate. They're maybe going to start to become altered because they're not adequately supplying the needs of their body. That 0.3 milligrams of epinephrine for your adult patient is going to be integral in your treatment of this patient because that fixes all of these issues. Here's our route for our septic shock. So, number one, we have a source of infection. Eventually that infection gets out of control and gets into the bloodstream, and the bacteria in the blood will cause the vasculature to become leaky. It will also cause the vasculature to dilate. So now, just like in anaphylaxis, we have leaking tank that's too big. So we already don't have enough blood to fill it, and now it wants to leak as well. So that is going to cause perfusion problem. It's going to cause organ dysfunction. It's going to cause issues with the brain, the lungs, the liver, the kidneys, the heart, you name it. It's going to cause us some problems. It's going to limit cardiac output, so it's going to limit how much blood the heart is actually able to pump out. It's going to limit stroke volume, so it's going to limit the amount of blood that actually is able to be pumped. Preload is that blood flow returning to the heart that I've been mentioning all along. Preload means how much blood is actually getting dumped back into the heart so that the rest of those things, the stroke volume, the cardiac output, and our systolic blood pressure and perfusion can continue to maintain itself. So if oxygenation is the problem, oxygenation and transport is going to be the solution. Sepsis has become such a big deal that we actually have a protocol for it in Massachusetts. We have a sepsis alert that we will call into the hospital because these patients are so sick that they have a legitimate chance at dying right in front of you. So let's take a look at our sepsis criteria here for a minute. And I want to ask you about this temperature one. Let's talk about this top bullet point. Now, we don't carry thermometers, but would a patient, just for argument's sake, if you touched a patient who was 100.4 degrees Fahrenheit, would they feel pretty warm?
Probably.
Yeah, I would say so. And the body's usual reaction to one of these types of infections is to generate a fever. So your patient who is 100.4 degrees, yes, they are sick. But this is your body's response. This is what your body is supposed to do, is generate this temperature right here. Should your sepsis patient feel 96.8 or really kind of progressively cold and almost chilly? What does it mean if your patient who you think is septic is cold to the touch? Come on, somebody take a crack at it.
I'm sorry, it skipped. I missed the question.
So if your patient who you think is septic is actually cold to the touch, this 96.8 degrees Fahrenheit, what do you think that says about what's going on inside their body?
It's failing. Something's like,
I'll take it. Yeah, their body's normal mechanism for dealing with this kind of insult is no longer going on. It has failed to accomplish the task at hand, and now it is starting to go from compensation to decompensation. If we look at some of these other things, our heart rate, if we have a patient with a known source of infection who's got a pulse rate of 90 or more, they're starting to get tachycardic. Tachycardia is one of the ways that your body actually deals with being in shock. Respiratory rate, 22 breaths per minute or more. Now let's start looking at some of this other stuff. Systolic blood pressure of less than 90. Now, as far as I'm concerned, a systolic blood pressure of less than 90 is always clinically significant. Unless my patient is pediatric, an adult with a blood pressure of less than 90 millimeters of mercury is way too low. And then we get to new onset of altered mental status or increasing change in their mental status. Why do you think this patient's becoming altered?
The brain's not getting enough oxygen.
And the brain's not getting enough oxygen, and really whatever is getting up there is just not accomplishing the task at hand. So we start working our way through this thing, and some of these bottom two, like serum lactate's not something that you'll see drawn in the field. And end-tidal CO2 is pretty much the measuring stick that paramedics will use for a lot of treatments. But if we look at just the nuts and bolts of these top few bullet points, and we start to see, all right, my patient feels cold to the touch. They have an increased heart rate. They have an increased respiratory rate. They have a decreased blood pressure, and they are Looney Tunes. It stands to reason that we have a sick patient. We need to call in our sepsis alert. We have no actual idea whether the patient is septic or not, but we've identified this trend in our patient condition. We have seen all the things that we need to see to actually verify and say, yes, this patient is not doing well. This patient is getting sicker by the second, and we need to do some things about it. And with that being said, we're going to take another short break, because now we're going to talk about what goes on inside the body, and then we're going to talk about what we can do to support it. And that'll wrap our shock lecture up in a nice tidy little bow. So take another 10 minutes, get up and stretch, think of any questions you might have, and we'll get to them, because shock is a big thing. And like I said, it's progressive, it's important, and the sooner we figure it out, the better off our patients are going to do.
alrighty, thank you.
All right, everybody, we are back. So we've talked about all the ways that this can go wrong. Now let's talk about the ways the body works to protect itself when shock has reared its ugly head. So we already have covered this ad nauseum. We need an adequate pump, an appropriately sized container, and enough fluid in the system to fill said container, and we will have adequate tissue perfusion. That's really the way all of this stuff works. When shock is first recognized inside the body, our patient's body's going to do some things. And those things are here. We're going to have some direct nerve stimulation. So that direct nerve stimulation is the sympathetic nervous system is going to send off epinephrine. That epinephrine is going to stimulate the vessels to contract. So we're going to shrink down the size of our container. So that way, even if it is a loss of volume, we've made a smaller container. Also, it's going to have some effects on the heart. So that sympathetic stimulation is going to increase our heart rate. So we are maximizing the volume we have left. That increased heart rate is going to pump blood around faster, which means it's going round and round and round quicker. So a smaller amount in a smaller tank is going to manage the problem for a little bit. On top of shrinking down the container and increasing the heart rate, it will actually increase the force with which the heart actually beats. So our heartbeat is going to be stronger. Cardiac output will return back to somewhat normal levels, and our patient will sometimes have an adequate blood pressure when we arrive at their side, if it's shortly after whatever it is that sent them into shock. Some of the other hormones that are going to get released are things like antidiuretic hormone. Antidiuretic hormone is now going to, instead of filtering out the blood and creating urine, it's going to pull all of that fluid back into the vascular system, because we're trying to make up for pressure loss. And by making up for pressure loss, we will get the blood pressure and thus perfusion back in line with what it needs to be. Those hormones, the antidiuretic hormone, the epinephrine, are going to do a pretty good job at compensation. So on the left-hand side of our picture here, we have early signs, the compensatory stage of shock. So our patient's going to be a little restless, going to be a little anxious, going to be a little irritable or afraid. And really, that's a result of the epinephrine in their body. Epi makes people jittery. Epi makes people anxious. It makes people irritable. Epi also increases the patient's heart rate. Maybe we'll have normal to slightly decreased blood pressure. It won't be a blood pressure that we look at and think, oh, wow, this patient's really sick. We'll see that pale, cool, moist kind of skin. We'll have an increased respiratory rate. We'll have an increase in body temperature, because all of these stimulated things are generating more heat. This is the way the body's supposed to work. That is what that epinephrine is supposed to do. That's why it is called the compensatory stage. Our patient is still somewhat adequately perfusing themselves. Left unchecked, we go from all of these early signs and symptoms to our late or decompensated stage of shock. Now, if we look at the decompensated signs versus the early signs, you notice that they get worse as this kind of progresses and goes along, right? They also get a little bit more difficult to manage as this progresses and goes along. Now we have a patient who, instead of just being restless and anxious because they had that adrenaline rush, gets kind of listless and apathetic and sort of almost sleepy, or really confused, or they have a lack of ability to sort of converse with you, or if they do, it takes them a really long time to get that level of brain activity flowing. Their heart rate goes from slightly increased to very, very rapid. It's their body's last ditch effort at working to pump around what blood is left to wherever it needs to be. So we'll go from, a slight increase, maybe a patient who's got a heart rate of 110, 120, to now a patient who may have a heart rate of 150, and it may feel almost too difficult to count. We'll start to have that irregular, weak pulses. So when we talked about that early on in this lecture, that's when we put our fingers to our patient's radial artery and maybe we hardly feel anything because we're having a pressure issue. Our patient's body has now really begun to shut itself down. as shock progresses, we go from an extremely rapid heart rate, then it gets to sort of its terminal point where it stops increasing and starts to slow back down. If your shock patient's pulse starts to slow down after it's already increased and increased and increased, do you think they just miraculously got better? You think
No.
the body just all of a sudden started generating new blood and pinching off all the leaking and got everything all squared away without any intervention?
No.
No.
No, this patient is now progressing deeper into shock and further into the decompensated stage, and we're getting ready to have a patient who will be assuming room temperature pretty quickly. We'll start to see a pretty marked decrease in blood pressure as this progresses and goes along. All of your patient's vital signs as we near the later stages of shock begin to start working their way back down to zero. Their body temperature is going to decrease. Their respiratory rate is going to increase just like the heart rate and become really, really rapid and shallow. And then it's going to also reach its terminal point and begin to slow back down. Our patient goes from sort of responsive and maybe just a bit slow on the uptick to now they're getting difficult to arouse and their speech is becoming slurred. So their brain function is beginning to become more and more impaired. These depressed or absent reflexes, these are the patients who don't have that response when we tickle the bottom of their foot, or the patient that we can put an OPA into, but they still have a pulse and a respiratory rate. Our blood pressure will start getting fairly low systolic, and maybe the diastolic will actually become zero. We may actually never hear any change. Their pupils will become dilated and really, really slow to react. So when we shine that pen light in their eye, it takes a long time for that pupil to finally constrict, if it does at all. And then when we take the pen light out, it will take a long time for that pupil to open back up. And everything is just turning itself off because the body has now failed. It is now no longer able to compensate for the insult that it's under. Once we make our way through the late signs of shock, we get to irreversible. Once shock becomes irreversible, this patient will die. There is no ifs, ands, or buts about it. It might not be in your ambulance. It might not be in the emergency room, but this patient has suffered something that is unsurvivable. So it is on us to, as we approach, look at these early signs and symptoms, because I'm going to ask you guys a couple of questions now. When do you think you would notice this first bullet point? Restlessness, anxious, irritability, apprehension.
On arrival?
On arrival, yeah, when forming our general impression. Moving on down to the next bullet point. When do you think you would notice a heart rate that you felt was slightly increased or just a little too fast?
When we're starting our assessment?
Yeah, a primary assessment. We'll skip over the blood pressure. What about pale, cool, diaphoretic skin? Before we make our transport decision, what's the last part of our circulatory assessment? During our primary.
Assess the skin tone and.
Yeah, skin color, temperature, and condition. What about respiratory rate?
While we were doing our primary?
Yeah, so all of these early signs and symptoms of shock are things that we can figure out pretty much the second we get right next to our patient. There's no fancy assessment that goes along with it. There's no fancy tools necessary for it. We match up what is reported as what's going on with the patient, whether it's a trauma or whether it's a medical. If our patient is still, well enough to speak to us, we get a brief chief complaint, and then we look at that information coupled with all of these things that we should find in our primary assessment. And we can say right then and there, certainly enough, is my patient likely to be in shock? It's a simple yes or no question. And if the answer to your question is yes, we are absolutely officially on the clock to try and beat these things to the emergency room. So our treatment for shock, we're going to oxygenate. We're going to keep our patient warm. We're going to lay our patient flat, and we are going to transport them. What do you think our transport decision is for this patient?
High priority transport to the most convenient facility with ALS, intercept, and route.
You got it. Give that man a cigar. We are going to transport this patient to the closest appropriate facility. High priority with an ALS intercept en route. Because this is one of those times where we are officially in a hurry. Because really, we're trying to win the race. We're trying to beat the dragon. And the more progressive all of these things get, the more difficult they are to manage. And the more difficult they are to manage, the more negative they are for our patient. And the sooner we can get on about the business of recognizing these problems, recognizing what maybe the cause is, and doing what we can to start to reverse some of the causes of all this, the better our patient's going to be. Sometimes trying to fix a patient who's in shock is like trying to pee into the ocean to warm it up. But sometimes, like things with anaphylaxis or tension pneumothorax or oh God, I forget all the way back to that slide what the other one was that we could do something about. Well, we can even talk sepsis or hypovolemia. If we can stop right now, whatever it is that is causing our patient to be in shock and progress into shock, say with an epinephrine autoinjector, or say by tourniqueting that external bleed, or realizing that my patient is well on their way into septic shock and is going to need some pretty aggressive management when we get to the emergency room. So I call in that sepsis alert appropriately. We can at least delay our patient's progression from early to late and hope that we get them into the emergency room rapidly enough to keep them from here. And the hospital will do what they need to do to actually stop the cause, reverse the issues, and reperfuse all of those tissues by increasing their oxygenation or whatever they're going to do to make this patient better. And we've now appropriately treated our shock patient. So our assessment for someone we think might be in shock starts the minute we receive the call. As soon as we get a call for service for a significant trauma or a patient who is allergic to bees and got stung by a bee, or has, the one we get from the nursing homes all the time, patient's been diagnosed with a UTI and is now altered. Right then and there, we can talk about the signs and symptoms that we already can expect, the things that we already know, and from there, we can start planning out how we're going to respond to this call, how we are going to assess and treat this patient, and how we are actually going to do our examination and get this patient sorted out. The signs of poor perfusion are visibly evident. We will see a patient who is altered. It's pretty easy to pick out the people that have an altered mental status. We will see that pale, cool, clammy skin. When we pinch the nail bed, we'll see that delayed capillary refill because that is measuring the perfusion, oxygenated blood being delivered to the tip of that little finger. We will feel weak or absent peripheral pulses because there's not enough pressure left in the system to actually be able to maintain adequate perfusion out to the periphery. And we'll be able to start taking the steps that we know that we need to take and doing the things that we've already talked about needing to do, which is what again? What is our treatment for these shock patients?
Keep them warm.
All right,
Lying flat.
lay them flat, yep.
And oxygenated.
Yeah, oxygenated. When we get right down to brass tacks, the problem here is delivery of oxygen and removal of carbon dioxide. So we need to start fixing the delivery of oxygen and removal of carbon dioxide, the keeping them warm while we're trying to limit any further expenditure of energy because they don't have enough oxygen or glucose to create the energy that they need already. And we just keep on about our business and get this patient transported. So there are some age considerations. There are some medicines and such that can actually delay our patient's ability to compensate. When we talk about the elderly folks are often prescribed multiple medicines. Generally, they start having maybe some issues with their heart as they get older. They start having some issues being able to control their blood pressure as they get older, so they wind up on medicine for that. And some of the medications that are very, very popular to be prescribed for blood pressure management make an elderly person's ability to compensate for shock a complete and total nightmare. That epinephrine that gets released into our system to stimulate our body's compensatory mechanisms and have our patient continue to do sort of well when they've been exposed to something that will put them in shock. Some of the neuroreceptors that epinephrine respond and react to are called beta 1 and beta 2. Some of the most prescribed blood pressure medicines are what are called beta blockers. So right out of the gate, those beta blockers are going to interfere with the body's ability to actually stimulate that response. So when we show up and Nana has been a victim of something that is going to put her into shock, whether it's a peanut that was ill-advised or a bee sting that she really couldn't maintain, she's not going to be able to raise her blood pressure. She's not going to be able to increase her heart rate or increase how hard her heart squeezes or really even constrict down all of that vasculature because she's taking a medicine that actually takes that right off the table. So when we show up to an elderly person who's had some event that will cause them to go into shock, whether it's obstructive, whether it's cardiogenic, whether it's neurogenic, whether it's hypovolemic, respiratory, metabolic, makes absolutely no difference at all because all of those compensatory mechanisms, the early stages of shock, have been pulled right off the table and they deteriorate very quickly. And you may arrive to find them in a state that doesn't necessarily jive with what you expected because they get so profoundly ill so quickly that sometimes we never even see any response. We wind up, already in the late stages of shock because the body is unable to mount that response. Kids, on the other hand, they're little tricksters, I'll tell you that, because kids have the ability to increase their heart rate to a huge level. Kids have the ability to clamp down their vasculature, and we'll see those skin color, temperature, and condition changes very, very early, and they will shut down all of that peripheral circulation to keep all the blood in the middle where it's going to do its most good. And they trudge along like that for a good long while until they don't. And after that long period of compensation, they decompensate suddenly. It's like somebody flipped a light switch and they go from compensated shock to very, very late stages of decompensated and possibly even irreversible shock. Kids don't have the same blood volume as we do. An adolescent will have somewhere around 2 liters of blood in them. depending on age and weight. Our average adult will have somewhere between 4 and maybe 6 liters of blood inside of our vasculature. A pediatric patient, a young pediatric patient, infant to first year of age, they have about a 12-ounce can of soda's worth of blood floating around in them to accomplish the exact same amount of work as being a human as we do, just on a smaller scale. So we need to really keep on our toes if we have a child who's been involved in, say, a trauma, or has been involved in something that will cause anaphylaxis or sepsis. Our goal in the management of shock is pretty simple. We're going to secure and maintain an open airway. We're going to assure adequate ventilation, whether that means the patient has an adequate respiratory rate, rhythm, and quality, or we have to ventilate them. Que sera, sera. We're going to provide that high flow, high concentration oxygen, so a non-rebreather mask at 15 liters per minute. We're going to pay close attention to our patient's respiratory rate. If we're ventilating, we want to make sure we do that one breath every 6 seconds, nice and slow and controlled. We want to make sure we didn't miss any external bleeding in our primary assessment. And really, and you'll see this when we start talking trauma assessment, I believe next week, our goal here is to get this patient off scene and en route to the emergency room as soon as humanly possible. Whenever prudent, a patient who's in shock needs to be transported right away. Now, that's not to say that we ignore the whole rest of our assessment. That's not to say that we don't provide the treatments that we need to. But if we are sensing shock and thinking shock, and we're seeing these compensatory mechanisms right off the bat from our primary assessment, our transport decision needs to be made early, and we need to make sure that we are following that. Closest appropriate facility with an ALS intercept en route. And we need to just know that we need to move with a little bit more purpose, and we need to be working just a little bit faster to make sure that we have a salvageable patient when we get to the emergency room. Rapid transport and an ALS intercept. That's going to be the word of the day for our shock patients. Keep them warm, ensure that our ABCs are maintained, ventilate, oxygenate, open, clear, and secure airway, stop any external hemorrhage, and keep these people warm, and then get them to the ER.
When we talk about ischemia, we're usually talking about this lack of blood flow to a specific area of tissue. A coronary artery in the heart gets blocked that supplies the left ventricle with blood. So that localized area of heart tissue doesn't get enough blood and oxygen, and that damage is localized to that left ventricle. Shock is like ischemia, but on a global scale. In other words, it's a whole body circulatory failure, where blood flow to tissues is dangerously low, leading to cellular injury, possibly damaging multiple organs, and even leading to multiple organ failure if not treated immediately. Okay, so with shock, the body's tissues aren't getting enough oxygen via the blood, right? Normally, blood perfuses through tissue and delivers oxygen because there's enough pressure in the circulatory system to push it through. So blood pressure is a major determinant for the amount of blood perfusing through tissues. Now, blood pressure is determined by two components: the resistance to blood flow in the blood vessels, things like vessel length, blood viscosity, and vessel diameter, and the cardiac output, which is the volume of blood pumped by the heart through the body per minute. And you can break that into heart rate, the number of beats per minute, times stroke volume, the amount pumped out each beat. Going even further, the stroke volume is found by taking the total volume of blood left over after contraction, the end systolic volume, and subtracting it from the total volume in the heart after filling, the end diastolic volume. All right, now keeping all those in mind, shock can be caused by a whole bunch of different things, but we can categorize the different types of shock into three main categories, along with some subcategories here and there. The first category is called hypovolemic shock. Hypo means low, vol refers to volume, and emia refers to the blood. So hypovolemic shock is shock induced by a low fluid volume of blood. And this could be either non-hemorrhagic or hemorrhagic. Non-hemorrhagic means that the loss of fluid volume isn't from bleeding. So this could be like if you were stranded in a desert and suffered severe dehydration. Eventually, your loss of fluid and sweat would reduce blood volume to where it wouldn't be enough to supply your body's organs, and you develop hypovolemic shock. Hemorrhagic hypovolemic shock, on the other hand, is loss of blood volume through ruptured blood vessels, in other words, from bleeding. A loss of about 20% of your total blood volume, roughly 1 liter, can be enough to induce hypovolemic shock. And when that liter of blood leaves the circulation, the total volume filling into the heart goes down, meaning the end diastolic volume goes down, right? This means stroke volume goes down as well, which causes cardiac output to go down, and finally we see that blood pressure goes down. When cardiac output goes down, catecholamines like epinephrine and norepinephrine, ADH and angiotensin II are released, all of which cause vasoconstriction of blood vessels, which increases vascular resistance and increases heart rate, which increases cardiac output. And these combined effects all increase blood pressure. A super important indicator of tissues not getting enough oxygen due to hypovolemia is a decreased mixed venous oxygen saturation, or MVO2. MVO2 is the amount of oxygen bound to hemoglobin in blood coming to the right side of the heart from the tissues. So it's like the amount of oxygen left over or not extracted and used by the tissues. So if blood volume's down, that means oxygen's down, and there's going to be less left over, right? So MVO2 will be down with hypovolemic shock. Since blood flow provides heat to the tissues as well, when it's down, the skin starts to feel cool and clammy, and so hypovolemic shock is considered a cold shock. A second main category of shock is cardiogenic shock. Cardiogenic means produced by the heart, right? So this is when something happens to the heart such that now it can't pump enough blood to the body's tissues. The most common cause is acute myocardial infarction, or heart attack. Hold on a second though. Didn't I say at the beginning that that was more along the lines of localized ischemia? Well, the heart attack itself reflects ischemia, right? But these effects of the initial cardiac damage eventually leads to a state of shock. When the heart's muscle cells die, it can't contract as hard, which means the amount of blood pumped out, or stroke volume, goes down, and therefore cardiac output goes down as well. In the same way as with hypovolemic shock, the body releases vasoconstrictors to increase vascular resistance and help maintain blood pressure. Also, as with hypovolemic shock, MVO2 will be down since there's less oxygen being pumped out, and so less will be left over. Sometimes there might be an obstruction that doesn't allow the heart to fill properly with blood. For example, we might have the pericardial sac fill up with fluid from an infection or blood from a traumatic accident, like getting stabbed in the chest. If this sac fills up, it physically constricts the heart from expanding and contracting normally, and also reduces the stroke volume. This is sometimes subclassified as obstructive shock. But you can see that the cause is still due to the heart's inability to do its job, right? Similarly to hypovolemic shock, a reduction in cardiac output leads to lowered blood flow, so the skin gets cool and clammy, and so cardiogenic shock is also considered a kind of cold shock. All right, the third main category of shock is called distributive shock, where there's typically a leakiness of blood vessels and an excessive amount of arterial vasodilation, or widening of the peripheral blood vessels, which remember is one of the components of vascular resistance. If arterioles dilate, vascular resistance to blood flow goes down and blood pressure goes down, leading to less perfusion and distribution of blood to organs and tissues. Now, the most common type of distributive shock is septic shock from pathogens in the blood. What happens with septic shock is endotoxins, these large, clunky lipopolysaccharide molecules, sometimes just called LPSs, found in the outer membrane of gram-negative bacteria, causes a crazy cascade of events that ultimately leads to lowered perfusion. First, these guys directly damage endothelial cells and cause them to release vasodilators like nitric oxide. They also activate the complement pathway in the blood, which stimulates mast cell release of histamine, another vasodilator. The LPS molecules also activate immune cells like macrophages and neutrophils, which help create a bunch of pro-inflammatory cytokines like tumor necrosis factor and interleukin-1. These help the immune system destroy the invaders, but they also stimulate the endothelial cells to release more inflammatory molecules like platelet activating factor and reactive oxygen species. All of these inflammatory chemicals damage the endothelial cells and increases their vascular permeability, making the blood vessels leaky. Also, endothelial cells express a procoagulant called tissue factor. Procoagulants are molecules that increase blood coagulation, or blood clotting. And this, in combination with an overall decrease in anticoagulants, which usually decrease clotting and seem to be often depleted or used up during sepsis, leads to this net increase in coagulation and clotting in the microvasculature. And of course, clotting and blockages in the blood vessels further decreases perfusion, right? Okay, so this widespread vasodilation means very little vascular resistance, and blood can't get the chance to unload as much oxygen as it cruises through the vasculature, and it gets back to the right side of the heart with leftover oxygen. So in this case, as opposed to cardiogenic and hypovolemic shock, MVO2 can be normal or even increased. In contrast to hypovolemic and cardiogenic shock, now there's an increase in flow in the peripheral blood vessels, and the skin becomes warm and flushed. So distributive shock is a kind of warm shock. The overall combined effects of widespread vasodilation, increased vascular permeability, and microvascular blood clotting all contribute to decreased perfusion of blood to vital organs. Now, two kind of subtypes of distributive shock are anaphylactic shock, which is an allergic reaction that causes dangerously low blood pressure, and neurogenic shock, where the nervous system gets damaged and can't control the body's blood pressure. The treatment of shock depends on the cause. In general, the goal is to stabilize blood pressure so that vital organs like the heart and the brain are perfused with blood. In order to stabilize blood pressure, fluid replacement and medications that increase heart contractility, cause vasoconstriction, and retain fluid can be administered. Oftentimes, a person might need supplemental oxygen or have their airway protected, for example, with intubation. All right, as a quick recap, shock is ultimately a failure in tissue perfusion, and it affects the whole body, putting tissues and organs at risk for injury and ultimately organ failure. Hypovolemic shock happens when dehydration or hemorrhage reduces the volume of blood in the blood vessels. Cardiogenic shock happens when a direct injury like a heart attack or an obstruction like a pericardial effusion prevents the heart from pumping blood efficiently. Distributive shock happens when something like an allergic reaction or damage to the nervous system, called neurogenic shock, causes the blood vessels to vasodilate and become leaky, which reduces the resistance and lowers the blood pressure.